If we understand the incidence and time of onset and causes of patellofemoral instability after calipered kinematically aligned total knee arthroplasty, then we have a better chance of reducing the risk of it ever happening. We performed a study in which we looked at the clinical characteristics and radiographic parameters that were associated with patellofemoral instability. We studied 3,212 patients and found 13 that presented with patellofemoral instability after kinematically aligned total knee arthroplasty for an incidence that was very low, 0.4%. In 9 of these patients, the process took a while, and atraumatic subluxation occurred at a mean of 5 months. So what went on in the first 5 months to make these patella unstable when they were stable initially? Active motion caused the lateral subluxation and extension and reduction in 15 to 30 degrees of flexion, as you see here. But curiously, if you passively moved the knee, no instability occurred. The causes were identified by a 1-to-3 match of patients with patellofemoral instability to a group of those in our database without. Patients with patellofemoral instability had a mean of about 5 degrees more flexion of the femoral component than controls, a surgical error that's treatable. Mean flexion was 6 degrees in control patients without patellofemoral instability, and this image shows a person that has 2 degrees of flexion. Mean flexion of the femoral component was 11 degrees in patients with patellofemoral instability, as you see here. And so what's curious is that when you flex the femoral component every 5-10 degrees, you reduce the size 1 to 2 times, and you reduce the proximal coverage of the femur, which delays the engagement of the prosthetic patella or unresurfaced patella in the prosthetic trochlea. Flexion of the femoral component reduces the lateral and proximal coverage of the femur, so you want to minimize flexion of the component. Here we see 2 different knees. Here we have the lateral and proximal coverage of the femur after kinematic alignment of the femoral component in 0 degrees of flexion, and the outline there shows the lateral uncovered region, and the blue dot shows the limit of the proximal coverage. And then when we flex the femoral component 10 degrees, we have to downsize 1 or 2 sizes of the femoral component to avoid liftoff anteriorly, and you can see there's a substantial reduction of the lateral coverage and a substantial reduction of the proximal coverage of the femur. And this then leads to a higher risk of delayed engagement of the prosthetic patella button or implant into the prosthetic trochlea. Patellofemoral instability occurred in those patients with dome patella implants, another risk factor or cause. We speculate that soft tissue overgrowth of the dome implant, which is relatively small, reduced the congruency at about 5 months, hence the time dependent or the passage of time was required for the instability to occur, and explains the atraumatic onset. This is just an eversion of the patella showing the soft tissue on a dome button. We can lift up a little piece of it so you can see how it reduces the convexity, and then you can see once the soft tissue is removed, the convexity is fairly well restored. Patellofemoral instability did not occur with an anatomic patella component, nor with an unresurfaced patella. Here you can see an anatomic patella implant giving good congruency within the groove, and because of its broader surface area, is less likely to have a large amount of overgrowth from the soft tissue. Here's an example of a patient with an unresurfaced patella. However, as you can see, oftentimes the cartilage on the patella wears, and it's our view that you should replace the patella or resurface the patella, if you will, with an anatomic button in all patients with kinematic alignment, as we found that it lowers the Oxford scores and forgotten joint scores. So now we resurface everyone.